Okay, so I'll click record then, just to be safe. Was that our conclusion?
Yes. We'll
Okay,
both.
I'm doing it. Cool. All right, record to the cloud. Oh, wow, I'm recording. Excellent. All right, recording has begun. Perhaps multiple recordings. And everyone, just a reminder, if you're on video, we can see you, which means if you go to the bathroom or pick your nose, we see that too. And it has happened in recent days to many people. So just be vigilant. So if you do have to do any of those things, just turn your video off, please. Okay, well, we'll get things started. So thank you everybody so much for joining. I'm not going to share my screen just yet. I don't think we need to, but I want to kick things off. I'm going to put everyone on mute just to get us started. So here we go. Mute all. Okay. Excellent. So everybody should be muted, hopefully. That way we just don't hear any background noise. So thank you everybody so much for joining. We're very excited to be organizing our first HKS New England Alumni Association virtual event. We'd had obviously many events scheduled in person, and things didn't go as planned. So we are very pleased that Rosemarie has been flexible and willing to do this very exciting session with us virtually. So this is our first one. We're testing it out. We did also have a community conversation last Friday, which was a really nice, intimate conversation with community members. If you do want to see those notes, I can share them with you. I'll leave a little chat feature. So for those of you for whom this is your first Zoom call, I bet many of you are experts at this point, but I'm just going to set a few sort of ground rules just so that we're all on the same page. So you are welcome to keep your video on. It's totally optional. But please make sure that you're on mute unless you're speaking. I have taken the liberty of muting everyone, so I think we're okay there. And again, a reminder, we can see you if you're on video. We will have time for questions and answers in this presentation. In the meantime, if you have any questions, then just leave them in the chat box. So the chat box should be to your right. So if you look to the right of your screen, you should see a chat option. Also, you should see it at the very bottom of your screen. It should say chat. If you don't see it, let me know, and I will assist. But yeah, so please do chat if you have any questions. You can chat to everyone. And what we'll do is that as we approach the Q&A section, we'll just go through the questions in the sequence in which we receive them. And then we'll have time for questions that haven't been chatted as well. If you chat me and or Rosemarie, please be aware that we may be screen sharing. And so those comments may be made public as we screen share. Additionally, please, if you would like, raise your hand. There is a button. So if you click participants, no, let's see. You should be able to raise your hand. So there's a few ways of doing that actually. If you click participants at the bottom, it should pull up the raise hand option, but also on your individual screens, you should see it. Again, if you have any questions, let me know. That's a helpful way of facilitating questions when we get to the Q&A. We are recording, so we will be able to share this after with those who were not able to attend now. And that's it. So any questions before we get started? And I turn over the microphone to Rosemarie Day, who will be talking with us about healthcare, which is a very, very relevant topic these days. Okay. I'm looking at my chat and I don't see any questions, so we're going to get started. So Rosemarie, I'm unmuting you. I'm going to mute myself and you should be able to share your screen as we get started. Thanks again for joining, everyone. We're very excited to have you here.
Okay, great. Thank you so much, Theo, for organizing this and for doing what we're calling the pivot to the virtual world and being so accommodating. And thank you to all of the people who are attending. I see so many familiar names and faces. So that is really exciting and gratifying. I appreciate it. I wish we could be in person, but honestly, we're actually having more attendees because we're doing it virtually. So that's a silver lining, I guess, in the situation that we're in. Let me just make sure that everybody, is the sound working okay, Theo, and all that before I keep talking? Okay, great. So we are all getting used to this way of doing things. And so I cannot say that I am an expert in manipulating Zoom. So I know how to talk into the computer, and I think I can screen share because I have a few slides for you. And then I will also be doing some portions of readings from the book that I wrote and that just got published. So that it's going to be a combination of like a back to the classroom session and a bit of a bookstore reading. And it's meant to be interactive. So again, I know we're all kind of getting familiarized with this environment, but I wanted to take some breaks through the course of the session to give you a chance to type in your questions or ask, raise your hand, whether you wave at the camera or you press that button if you can find it. I want to give you a chance to talk with me and with the group, so that we basically kind of build some community here in a virtual sense this evening. So delighted to have so many people here. Thank you for coming. I think that this COVID-19 crisis has only made this topic more relevant, and I think that Theo's alluded to that as she was opening up the session, that we really, really have to be looking at this point, what is our society valuing? And it is illustrating in the most dramatic way possible how fundamental our health is to our safety, our security, and obviously our well-being. It's an absolutely fundamental piece of our social fabric, and that sometimes I think, particularly when those of us who are in the healthy camp, which none of us always will be, but may take for granted sometimes. And this is reminding us, frankly, that we can't, and that we are all incredibly interconnected. So my point in writing this book was really to make the case for making healthcare a right in this country, and to make that something that, in particular, women would feel even more empowered to lead the charge on. And I have a lot of reasons for why I decided to take the feminist lens on this. You all hopefully got a copy of the first chapter from the book, and I start to lay out, both in my introduction and in that chapter, why I decided to do this. But certainly I initially chose to tackle this topic because the Affordable Care Act, I almost think of as like my fourth child. It is so near and dear to my heart, in terms of having had the good fortune to work on the prototype for the ACA here in Massachusetts back in 2006. And then in 2010, I left Massachusetts state government to try and go around the country and help other states set up their version of what we did in Massachusetts and be part of the Affordable Care Act solution. It's been a wild ride over the past 10 years, as I'm sure you all know. When the 2016 election happened, and with those dismaying results for any of us who care about healthcare and coverage for all, when the vociferous attempts to repeal the Affordable Care Act just seemed unrelenting, I felt that I needed to do something more than I had been doing, and I wanted to explain to people why the ACA was so fundamental and so important. It became clear that that wasn't going to be an interesting enough book. It's been relegated to one chapter in the book, and that what we really needed to be able to do in this era is to think to the future and really what vision do we want. And so I decided let's just go for broke and say we want universal health care, 100% universal health care, and that means making it a right in this country. So then I really started to tackle what that means in terms of cultural values, politics, all of the different elements. How would you go about making healthcare right, and who's going to be the driver of that? And my thesis is that women really need to be the drivers. So I'm going to talk about that as well in the course of this session. there are definitely some housekeeping things. I think Theo covered most of them. Because it's named Back to the Classroom, I am going to put up a few graphs, just a couple, so that you can, get a little data and learn a few things that way. But I am also going to just speak to you directly. So I'll toggle sometimes between showing a slide, sometimes just talking to you and then reading a few things, and then taking breaks to get your reaction to what I've been saying, to try to make this as interactive as possible. So there's only one time I'm going to ask you to do this, but we are actually going to take a quick poll. And that is because a very good friend of mine who happens to be on this session, who's an expert in teaching online, said, you want to get a sense of, like, everybody would like to kind of know who's in the room, because if you were actually sitting in a bookstore like we were several weeks ago, you could kind of look around and get a sense of the crowd. You can kind of do that by looking at your screens, but we thought it'd be fun just to see, all right, what category are you in age-wise, so we get a quick demographic look. And then the second question is about your health insurance status. Very simple, just whether you feel comfortably insured all the way to uninsured. And then if you're worrying about anybody and their your immediate, family or close friends. So just take a moment to, you should just be able to click on your screen, choose a button, and then it automatically goes into the big hopper and gets compiled, and we can just see who all's here and why they're here. As I keep saying to all my colleagues these days, we're all learning new skills. So, you haven't done a poll like this before, new skill. And then if you're waiting for the responses, they're coming in. Hopefully Maria's getting them. The other thing I would ask you to do is, if you have any Post-it notes handy, that nice big little pack of Post-it notes, I'm going to be asking you to write on Post-it notes or some piece of paper that you'll be able to take away from this session. So it's our very low-tech solution to engaging you in yet another way, but get your notes ready.
Hey, Rosemarie, I'm going to post the results. It looks like all of them are in.
Okay, great. Who have we got? Do I see? Yes. Okay. A nice bell curve on the age. A lot of people in my demographic. Thank you. Okay, a nice mix. Great. Thank you. So can we scroll down? We see age. Can we scroll down and see how you describe your current health insurance status? Or maybe that's for me to do. Yes. Okay. All right. So we don't have anyone who's uninsured. That's good news. A lot of people comfortably insured, but a significant number who are worried about affordability. Very fair. And then the last question was, are you worried about anyone else's health insurance status? And it looks like over half of you are. Okay. All right. So that gives you a sense of who we've got and potentially a little bit of like why you're here. Or maybe it's just because you know me and you wanted me to feel like I had an audience. Thank you. That's your reason. All right. I'm going to pivot then in just a second. What I want you to do, I asked you about those Post-it notes. So this is how I want you to use your Post-it notes. There's going to be 3 things. First is, if you have questions that you want to ask as we're going, again, I'm not going to save it all to the end, so we'll take breaks, but sometimes it's just good to jot those down, especially if you're not as comfortable with typing into the chat feature. So just use your Post-its for your questions. The second reason for the Post-its is if there are facts or stories that I share that are compelling to you or interesting, or just you have questions about, please jot those down. And then the third thing is, while we're going through this, I would love for you to be thinking about who else do you know who needs to hear more about this topic. My goal is both to inform you and to inspire you. So you could be thinking of folks who maybe are very well informed, but they are feeling very discouraged. I spent some of November in Kansas working with people like that who were just really trying to get to Medicaid expansion after 7 years of just slogging, and they were so discouraged. So there's always, a need for more inspiration. But there are a lot of people for whom this is not a topic that they know a lot about, and it's not a comfort area of knowledge. And so informing is a really good first step. Okay, so be thinking about people you might want to engage. Okay, so with that, I am going to move into screen sharing. Okay, are you able to see this PowerPoint slide, or did I not absolutely share this?
Not yet.
Okay, I think I have to choose share screen first.
Yeah, there are a few options that present themselves. I would click the slides. There's a few sharing screen options.
Mm-hmm. Okay, so I'm going to go to this screen. Okay, there, it should be there.
Perfect. Yeah, we see it.
Great. New skills. Okay, so this is, so my talk is about how women can lead the fight for universal health care. Also happens to be the subtitle of my book. And you will see that there's a big theme about marching, marching toward coverage. That may mean today in a more virtual sense than actually getting into a big crowd and marching, but I am hopeful that we will be able to be in those crowds again. So I want to first just give you some of the landscape as to what the coverage picture looks like. This is actually the same graph that's in the first chapter of the book. It's just in color here because we can have color on our slides. And I wanted to give you just two data-oriented slides, this one and then one that isn't in the book. So the key thing here is that I talk about a metaphor of a patchwork quilt of coverage, and that it's very bare in some spots, completely bare, sometimes threadbare. So there's real variation within each of these categories. But just keeping it at the simplest level, the thing to know, as we move forward in our discussion this evening, is that the vast majority of folks in the country who are not of Medicare age are getting their health insurance coverage through employer-sponsored coverage, meaning that it is attached to their job. And it may not be their job, it may be a family member's job. So it could be, this includes the kids, the spouses, significant others who are able to be covered through an employee's insurance. So when you take the Medicare population into account, that means it's just under half of our overall US population is covered by some form of job-sponsored insurance. And so that is a very significant fact to keep in mind, because that is our starting point. And when you think about how we get to ultimate solutions, we cannot ignore the fact that a lot of people are in this category.
Rosemarie, this is Maria. I'm just going to interject. Yeah. Your slides are not advancing.
I'm not advancing it.
You need to correct. Yes, we just see the main slide. So the slide is not advancing. Are you in presenter view?
I'm in share.
Can you, if you click on the slide what slide do you see on your screen?
I saw the next slide, which was the pie chart.
Yeah, and you see it right now, the pie chart.
Mm-hmm.
Oh, interesting. Huh. If you want, Rosemarie, if you want to send either Maria or I the slides, we can present on your behalf.
I have it to present.
Maybe Maria,
okay.
that would be helpful.
1 second, please.
Thank you.
Okay.
just to make sure that everyone can see the slides.
Yeah, that'd be good. I can keep talking while you do that. Thank you, Maria. So you'll see when the slide comes up that that's like half of the coverage picture. The next piece that you'll see is that there's this sliver that is the part of the market that are folks who do not have employer-sponsored insurance and buy it on their own. It's known as the individual insurance market. And there, I see it. Thank you.
You're welcome.
That is the light pink piece of the pie. And that is actually the entire, that is the market that Obamacare was largely focused on. That and the next one over, which is Medicaid in green. Medicaid was a base program, and the Affordable Care Act expanded the Medicaid program. But in the light pink sliver, that is the individual insurance market. That was for people who did not have employer-sponsored insurance, needed health care, and did not, and earned too much money to qualify for Medicaid. And that was a market that had a lot of problems, and the Affordable Care Act went a long way towards fixing them. The blue sliver is Medicare. That's for folks who are over 65 or who are disabled. There's a small sliver of government-sponsored programs that are for veterans and that are for Indian Health Service and a couple of other things. And then that last piece of the pie in kind of brownish wedge is the uninsured population, which at the time I wrote the book was about 9%. That is continuing to creep upwards based on a lot of the changes that have been made by the Trump administration and that correlate with some loss in coverage. So that's where we are today with kind of the coverage picture. If we go to the next slide, that will show you of that 9% that are still uninsured, this is how they break down. And so for those of you who don't want to stare too hard at the numbers, the big takeaway is that half of the people who are still uninsured, so that's the two blue half circles there on the right, they are eligible for some form of subsidized healthcare coverage in existing programs. So either they could qualify for Medicaid or they could qualify for a marketplace subsidy, meaning one of the Affordable Care Act exchange subsidies in that individual market that I mentioned. So half the people could potentially qualify for coverage. And then there are people who fall into various gaps, and largely the reason that they are not insured is because it's not affordable to them. So I'm going to let you just sit with that slide for a minute, and I'm going to read a little bit from the book where I talk about why people are left uncovered. And I start that chapter with a quote from Martin Luther King, which says, "Of all of the forms of inequality, injustice in healthcare is the most shocking and inhumane. Some 28 million Americans, 9% of our population, currently have no health insurance. That number includes more than 4 million children, which is a moral outrage that does not receive nearly enough national attention. For a country where most believe that healthcare should be a right, the percentage of uninsured is shockingly high, and worse yet, the number is starting to rise. How did we end up with a system that fails so many? Mostly because our patchwork quilt of health insurance coverage grew piece by piece and not comprehensively. It resulted from a series of reactions to historical circumstances, including market failures and limited political opportunities. Hoping for a win and knowing that political leaders feared backlash from the insurance industry and others, activists would often push for just one piece, such as AIDS activists did with the Ryan White Health Care Act of 1990, which provided coverage for needy people with HIV/AIDS and did not provide universal health care. Who are the uninsured? They are the 30-somethings who work in the gig economy, driving for Uber or making Amazon's deliveries. They are the 20-somethings who are waiting tables, whose parents don't have an employer-sponsored plan to add them to. They are the women who clean houses, work as personal care attendants, or are preschool teachers. The majority of uninsured people are low income, but contrary to stereotypes, the majority of uninsured people are working. And for those people lucky enough to be working and have employer-sponsored insurance, They are just one job loss away from having no coverage. This is an uneasy feeling for many. The uninsured tend to be millennials. Most are between the ages of 26 and 35 and earn a household income of less than $36,000 per year. Most have jobs or they live in a family with at least one employed person. People of color are at a higher risk of being uninsured, as are undocumented immigrants, who are often ineligible for Medicaid or purchasing a marketplace plan, depends on the state in which they live. Over a quarter of the uninsured in the US are actually eligible for Medicaid or the Children's Health Insurance Program, but are not signed up. So when health insurance is unaffordable, people become uninsured. In fact, the biggest reason they're uninsured is due to cost. The cost is high and growing, dramatically outpacing the growth in wages. And this affects people across the income spectrum. In fact, premiums for family coverage now cost more than a typical mortgage payment, and premiums for individual coverage cost more than a car payment. Life changes like divorce, graduation, and death of family members, as well as giving birth, switching jobs, and experiencing income fluctuations all contribute to uninsurance. A brief lapse in coverage is risky, but 2/3 of people who are currently uninsured have lacked coverage for more than a year, and they are in an especially precarious situation. Not only are the long-term uninsured living with no protection against catastrophic medical bills, they also aren't likely to be taking steps to detect and prevent more serious illnesses. People without health insurance are more than 6 times as likely as those with health insurance to go without needed care due to cost. They're also more than 4 times as likely to have no usual source of care, which limits a doctor's ability to recommend preventive measures and other care based on knowledge of their patient's health history. These numbers directly translate into mortality. During the height of the GOP's efforts to repeal the ACA in 2017, one Republican lawmaker famously said, "Nobody dies because they don't have access to health care." Nothing could be further from the truth. People without insurance are at a 3 to 41% increased risk of death. An estimated 26,000 adults between the ages of 25 and 65 died because they didn't have health insurance in 2010. In its groundbreaking report on the uninsured, the Institute of Medicine concluded that working age Americans without health insurance are more likely to receive, quote, too little care and receive it too late, be sicker and die sooner, and receive poorer care than when they are in the hospital, even for acute situations like a motor vehicle crash, unquote. Because uninsured people receive less preventive care and fewer screenings, their downstream costs and health consequences can balloon as conditions go undetected for longer. Women without health insurance have a 30 to 50% higher risk of dying from breast cancer because it is detected later, and when it is detected, they receive less extensive treatment. Uninsured patients also receive inadequate hospital services. They are less inclined to seek it, knowing that they will be sent a bill that they are often unable to pay, and the quality of care they receive is below average. This is because hospital staff know that the care they provide to the uninsured is likely to be uncompensated. So they offer fewer needed services and are less likely to admit an uninsured patient to inpatient care. This translates into a higher than average risk of death during hospitalization or immediately following discharge. The resulting outcome disparities are staggering. One study found that uninsured car crash victims are 37% more likely to die than their insured counterparts. The death of Amy Villela's daughter, Shalyn, is a tragic example of this outrageous situation. Shalyn was enrolling in nursing school and was in between insurance coverage when she went to the emergency room with a pain in her leg. Because she appeared to be uninsured, the hospital sent her home. They're telling her it's going to be very expensive. She can leave now. There's the door. It won't cost her anything, Villela said. They want us to see if we can get her on our insurance. The pain worsened, and a few weeks later, she returned to the hospital and she died of a blood clot that had traveled from her leg to her groin. Outraged at a healthcare system that allows people like her daughter to die because she fell between the coverage cracks, Villela decided to run for Congress in Nevada as a healthcare for all activist. So I go on to describe, you know, in more detail in the book how it is that we have incrementally built the system we have, and then how these gaps have continued to persist. So I want to just take a pause there and open it up for a minute and just see if people have any questions about the data or the story I shared so far. If there's anything that strikes you as compelling, please feel free to speak up. I'll take a sip of water and just see if there's anything you want to share. And if you raise your hand, I think Theo can unmute you also.
Yeah, so if you raise your hand, and I want to make sure I'm doing this correctly, I can unmute, or also you can unmute yourself if you'd like. And you can do that either by pressing unmute in the top right. It's a blue option in the top right corner of your screen, or *6 if you've dialed in by phone. So I'm looking through to see if anyone's raised their hands. It doesn't look, I don't see any hands raised. So please do feel free to unmute yourself if you have a question.
Okay.
I have a question. Thank you, Rosemarie, for putting all that data in front of us. I was just really curious, as you went through the pie slices, it seemed like the Affordable Care Act had a bigger impact on some slices versus others. Is it mostly the self-insured and the uninsured that were impacted, or is it broader than that?
So so I had showed on that pie chart, there was about 7% of the population in this individual market, and that was one of the primary targets of the Affordable Care Act, because that's where people with pre-existing conditions could be denied coverage or charged such outrageously high rates that essentially they couldn't afford to buy coverage. It was a very unregulated marketplace, and so it existed, but almost in name only, because hardly anyone could use it. So that was for the people who didn't have employer sponsored, and that basically leveled the playing field, made all insurers insure people, and regardless of health status, and evened out the pricing and opened up, therefore, access through those regulatory mechanisms, and then through creating exchanges, online, marketplaces where people could go and shop for this and not have to go insurer to insurer to insurer. It was all one-stop shopping, which back then was really an innovation. Now we're all so used to it, it doesn't seem like a big deal. So that was like a huge piece of impact. The other really big piece of impact was expanding Medicaid, because Medicaid is this program that runs state by state. So overall, 20 more million people are insured thanks to the Affordable Care Act, and about probably 60% of that is because of the Medicaid expansion. And so states were left to decide whether they wanted to expand Medicaid. That wasn't the intent of the original law, but after Supreme Court case, that's where we ended up, that it became a state option. And so 26 states have expanded Medicaid, 14 have not. Kansas is working on it, as I mentioned. So that leaves a lot of very low income people completely out of the insurance picture, because states could set their own rules for who qualifies for Medicaid. And there are some states that say if you're an adult and you have no children, you do not qualify for Medicaid. You have really nothing other than indigent care if you show up somewhere, if they happen to take you in. So some states are that harsh. Others will allow you on, but you have to have such a low income that you might as well have almost no income. And even for states that will allow families on, they will have, again, such a low income cutoff that it's like you need to, if you make more than $5,000 a year for a family, then you can be on Medicaid. If you make more than that, you can't. So what the Affordable Care Act is trying to do is say, you know what, we're going to make sure that every state closes that gap so that we get anybody who's making 100% of the federal poverty level, they can qualify for Medicaid. And think of the federal poverty level, not even. So there are states that are well below that. And so it was meant to just at least close that gap. And some states, especially in the South and in the Midwest, have chosen still not to. So there are some very poor people who have nowhere to turn. But in the states that chose to, it made significant gains in terms of coverage. I will mention one last piece, which actually fits into the whole piece of the pie of employer-sponsored coverage, which is that there used to be, it was allowable to have lifetime limits on benefits and annual benefit caps for everybody in job-sponsored coverage. Not all employers chose plans like that, but it was allowed. And the Affordable Care Act got rid of that. So people who have really, really serious health conditions, you know, parents of, there were these stories, you know, of parents with children with like hemophiliacs and others who would run out of their benefit, even though they had what was considered good coverage through their employer, but there were these lifetime and annual caps. So those are gone, those were eliminated because of the ACA. So when you talk about repealing the ACA, that's who could be affected as well. Finally, I should say that there are over 130 million Americans with pre-existing conditions. And while I showed that nice, neat pie chart, like, okay, everybody's in a category, the truth of the matter is we all move between categories through life. And there's almost no one who stays in a job for life anymore, very few people. So having your insurance tied to your job when you're in such a fluid job situation, and now with coronavirus, and you know how much job loss there's going to be, the fact that we're still tying our insurance to jobs is really challenging. That is not true in other wealthy countries. So job loss doesn't mean insurance loss at the same time. In our country, we still have those linked. So that is a very insecure kind of situation. And also, if you're somebody with a pre-existing condition, it's particularly insecure because you didn't have to worry about it if you had it through your employer. But before the ACA, once you lost that coverage, you may not be able to afford to buy it on the individual market, given the discrimination against your pre-existing condition. So a lot of people who right now, today, may be sitting in an employer-sponsored job, you know, insurance situation, if they're worried about losing that, they don't have to worry that they would be barred from getting coverage elsewhere. And that is a big, big change. So I think the Affordable Care Act has affected even more people, and people are starting to understand that than just if you look at that little pie chart.
Rosemarie, this is Julia. May I ask a question?
Sure.
Great. So exciting to see you presenting on the book. And I feel like everything you're talking about is 1,000 times more relevant now with COVID-19. So I know it's early to predict what impact this is going to have on our understanding of the changes that need to be made in the healthcare system, whether women have been disproportionately impacted in this particular pandemic. What are some of your thoughts around how COVID-19 will change public awareness around the need for stronger public healthcare system?
So I think that it is profoundly demonstrating that we are so interconnected in our health, that health is not just an individual matter. And sometimes when you see people argue against having something like universal health care, they'll say, well, if people would just take care of themselves, you know, then we'd all be fine. You know, if they would just exercise and eat healthy, which I think most of us kind of know is not true. Cancer can happen to anyone. You know, it's not, but sometimes it's just convenient to fall back on that. Oh, well, if individuals just did that, we wouldn't have to have a societal solution. I think COVID-19 absolutely shows that that is a completely false premise, and that we are more interconnected than perhaps many of us even realized, and that our health is affected in this interconnected way. And so the fact that people are going to be afraid to get, you know, even when there's enough tests available and treatment, there's such a gotcha mentality in our culture of like, you show up to the ER and you're going to easily be charged $1,000, if not more. And so even if there's messaging going out that, oh no, you know, we'll waive it for COVID, it's so ingrained in what people know that if they don't have insurance, that they could be left with this devastating bill. It's just not in our culture yet to really have that full safety net and what I call in the book a fleece blanket. So I hope that a silver lining from this really difficult time is that we can harness more collective will and energy around the fact that we should all have some baseline care regardless of your circumstance.
Thank you so much. And I've been thinking the same thing, and I wanted to hear your take on it, that if this, finally gets people to realize that healthcare is a human right, then at least there will be that, positive that came out of this terrible time. And thank you so much for how you're leading the way on this issue.
Thank you, Julia. I'm going to go back then, because what I just framed for you is the problem of having the lack of coverage or also being underinsured. I didn't go into that because I could be here all night talking to you, but there are a lot of people who technically have insurance, but the deductible is so high that they're afraid to actually access their care because they don't have thousands saved up. They can't meet their deductible. 40% of Americans have about $400 in savings. So if you have a high deductible health plan, you can't meet your deductible. So anyway, there's a big problem of underinsurance in our country as well. It's not just the uninsured. But what I want to turn to is part two of what I see the problem being. And so we'll go back into the slides for a couple of minutes if Maria is able to pivot. Thank you. Okay, so if we look at the role of women in healthcare, and I'm going to take it from the family level. One of the most fascinating statistics I came across in working on this book, and it really jived with a lot of anecdotal experience I was aware of, is that women are making 80% of the healthcare decisions in the typical family. And when you think about what that means during something like this pandemic, where we have to be ever more vigilant about all health-related matters, it means that the number and magnitude of those decisions has grown. So if you think of 80% of an even bigger base number, you're at even more burden, which is what I show in the second picture here. This becomes increasingly difficult. Not to mention all the things that women are typically juggling between work and home, and when you don't have children in school, et cetera. But that would be the topic of a different talk. So when you look at the fact that women are making the majority of healthcare decisions, and then juxtapose that with the next slide. If you can go to the next slide, Maria. She got stuck. So this would be an image that was first shown on Twitter. It was tweeted out galore in 2017, that this was the group in the White House that was discussing the ways to repeal the Affordable Care Act. I'll just say my blood pressure went through the roof when I saw this picture. So not only is it pretty much, looks to me like an all-white group, but obviously there are no women in this picture. So here we are, at the personal level, dealing with all of these healthcare decisions, and you go up to the place where the people with the highest levels of political power are convening, and there was not one woman in the room. Now, in subsequent years, once Nancy Pelosi became Speaker of the House again, I think we've all seen a picture of her being like maybe that one woman in the room. But this still is very prevalent in our political system. When you look at the makeup of Congress, even with the major advances that women made in the 2018 election, only 24% of Congress is women. So I will leave it at that. Moving on to the next slide. this is an interesting piece of data. It's from the presidential election in 2016, and I like it because it separates things by party. But the bottom line is that women are much more likely to prioritize healthcare issues when they vote. That was true also in the 2018 midterms. We don't have the data yet for the 2020 election primary stuff, but I'm sure people will be collecting it, and I imagine it will be the same. However, I think it's interesting just to see that if you split it, Democrats are in the blue, independents green, and Republicans red, that the skewing between the male versus female prioritization of this issue is virtually the same within the Democratic Party. Women and men almost equally prioritize healthcare, women just slightly more. Little less so in the independents, those who identify as independents. And then in Republicans, you've got 45% of women saying that healthcare is extremely important to their vote for president versus only a little over 25% of men. So there's quite a gender gap there. And I think that does reflect, the previous slides that I showed on what kind of decision-making women are having to do. As they say from the early feminist movements, the personal is political. And I think that translates into our healthcare priorities in voting. Okay. So let me just pause there for a minute. Does anybody have reactions to that? I see some things coming in on chat. Interesting about the gender gap on parties, how they're voting. Anything else to share? I think I haven't got all the chats opened up, but any questions that have come in, Theo?
I was going to say Lynn Wolsfeld had a very compelling personal anecdote. Lynn, if you wanted to tell us any more about that, we are open to it, if you want.
Hi, no, that was pretty much what I had to say. I mean, the implication is that if you go in for COVID ID or COVID-19, it's great that you don't have it, but then you're liable for the cost of whatever it is you actually do have. And for this, it was basically a flu test.
Yeah, that was a very tough story.
Yeah, and it's frankly kind of unclear about really how much of a COVID treatment is going to be forced to be covered by how that's going to be covered. I think is we're still all, even those of us working in this, are trying to figure out what that exactly is going to look like. TBD, I have to say at this point. Anyone else?
I think also there was one comment by Wendy Gully about women's bearing sort of maybe unpaid work, but work that's nevertheless very helpful and relevant in times of crisis. Wendy, did you want to elaborate? And let us know if you need help unmuting.
I certainly know Wendy. She's a dear friend and has devoted a lot of her life to caregiving for her children, and one in particular has some pretty acute needs, and so and that is all unpaid labor that it doesn't get recognized when we roll up, our economic measures, the GDP, and all that kind of stuff. There's a tremendous imbalance in how we think about what's valued, whether we put a dollar figure on it or not. And when you think about women's emotional labor, a lot of those kinds of things, and all of that piling up now, in particular with this pandemic, making everything an order of magnitude worse and harder. And then putting everybody in the same household, kind of in almost a pressure cooker situation. It's really fraught and very, very stressful time.
Can you guys hear me now?
Yeah, we hear you.
Okay,
I hear
sorry.
you, Wendy.
Yeah, so I'm undergoing chemo right now for stage 4 pancreatic cancer, and I'm still feeling like I have to plan the meals and figure out the shopping list and how to get groceries delivered. and the meal train. And, you know, I had an argument with my husband just today about, about all this. So, yeah.
I hear you.
Yeah. Just, you know, planning for the quarantine and everything, just feeling like you have to be the one to do it.
And the elderly parents and yes, the list goes on. And I feel for you, Wendy, and so many others. So I'm focused on the healthcare coverage piece, but so well aware and wanted, you know, to be clear that there is this context and that the pressure mounts. And so I keep going back to, and I'm going to move into more of the solution phase. I've put the problems out there, but I want to move towards what we can do positively toward this, because I will keep saying it, the personal is political, and we have to make our values of what we're doing and managing on the home front much more salient in the national political arena, which means we have to get comfortable with taking more power because enough is enough.
Rosemary?
Yes.
It's Diane. I had a question. I think Steve actually just typed it into the chat bar, but I was fascinated by those numbers that show independents have healthcare even less of a priority than Republicans, which to me was fascinating because as a Democrat, I feel like we talk about trying to go after those independent voters a lot, and to see those numbers are even farther away for the independents than they are for Republicans is a little concerning for me. And I just was wondering what your take on that was.
No, that's a really good question. What I would want to see is how it's parsed, because independents can lean left or lean right and essentially be more Democrat or more Republican. So independence is kind of like a catch-all that actually has a lot of differentiation. So my understanding is that the independents who lean left, if you look at them, then their numbers skew a lot towards like where the Democrats are. And then the to the right is the opposite. But it gets tricky with this polling data at, you know, how much they can really parse it. But this particular graph doesn't show that, but that's my understanding. Okay, so I'm going to move to read a short section from the part of the book that talks about how do we make healthcare a right in this country. So I build up, I explain in previous chapters how other countries have done it, how it can take lots of different forms of like how you actually implement it. It doesn't need to be all government run. It can include private sector roles. There's all kinds of ways to do it, but the commitment to making it a right is where we need to be, and then we can figure out details. That can all be hashed out. But fundamentally, we are a wealthy country that if we prioritize this, we could do it. So I'm going to read this portion because I think it's particularly relevant to our COVID situation. America is more than just a collection of rugged individualists pursuing personal freedoms and self-interest. Americans have realized the limits of individualism and turned to government in times of crisis. As President Franklin D. Roosevelt famously stated in 1933 during the Great Depression, quote, "We now realize, as we have never realized before, our interdependence on one another," unquote. Likewise, Dr. Martin Luther King Jr. wrote about interdependence in 1963 in his letter from a Birmingham jail. Quote, "Injustice anywhere is a threat to justice everywhere. We are caught up in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. Anyone who lives inside the United States can never be considered an outsider anywhere within its bounds," unquote. President Roosevelt set the stage for making healthcare a right in his 1941 State of the Union address, in which he defined 4 essential human freedoms, including freedom from want. He then called for a second Bill of Rights in 1944, his State of the Union address, including, quote, "the right to medical care and the opportunity to achieve and enjoy good health," unquote. Even though Roosevelt didn't achieve universal health care during his lifetime, these values were carried forward by subsequent presidents, including Harry Truman, John F. Kennedy, Lyndon Johnson, and Barack Obama. We ended up with more patches in the coverage quilt as a result, including Medicare, Medicaid, and the Affordable Care Act. Since many of America's leaders have supported making healthcare a right, it's only natural to have questions about what this really means. And I then tell some stories about author and surgeon Atul Gawande, who chronicled his conversations with his high school classmates. He grew up in Ohio, a very purple state, and he went back and just asked them a couple of years ago, what does it mean to you if we were to say healthcare should be a right? And they all were very clear. They said it shouldn't be a right unless it's also a responsibility. They said otherwise we might be undermining people's work efforts. And that they said, you know, one person's right to health care is another person's burden to pay for it. And they worried about if some people didn't deserve it. So that was from Middle America. This high-powered surgeon went back to his roots and said, what do you all think? And these are folks working as auto mechanics, all range of things, very different from how Dr. Gawande lives here in Boston. And I thought it was just kind of a good gauge of where people are when you talk about this. You know, this notion of the strong work ethic, what's deserving and undeserving, all of that factors into how we think about whether we can develop the political will to do this. But I will say it's countered by many other things. Ongoing genetic research is showing us that there are fewer areas than previously believed where illness is a person's fault. Recognizing that there's really a genetic lottery at birth helps to reduce the strength of the deserving and undeserving frame of reference. In addition, remember that most of the uninsured and underinsured are working people. They are proud and don't want to be perceived as taking a handout. They just want to be part of a system with decent insurance coverage that everyone else is in, and they're willing to pay in what they can afford. So in short, we can't talk about rights in America without matching them with responsibilities. Rights are as much about our duties as our freedoms. This was vividly on display for me recently, I guess not so recently because I wrote the book a year ago, but I attended a military gathering with my son, who is in Army ROTC. As we cheered the racing soldiers on, I was struck by the words on one soldier's sign, "Freedom isn't free." The men and women of our armed forces certainly know the meaning of duty and the price of freedom. As Americans, we should all be proud to accept certain responsibilities, and healthcare as a right should be one of them. Making healthcare a right in the U.S. requires balancing individual freedom with our responsibility to support the common good. It means turning individual freedom versus collective responsibility into a both and discussion rather than an either or issue, as public health experts Elizabeth Bradley and Lauren Taylor wrote in The American Healthcare Paradox. This balance embraces shared responsibility as embodied in the ACA's original three-legged stool framework. The ACA was unique because it made coverage both an entitlement and a responsibility of citizenship. In so doing, it advanced the idea of making healthcare a right, of having universal healthcare for the whole population and not just the subset by age or income. So now is the time to ask the question, do we want to make healthcare a right like education, or keep it as a commodity like a car? Making healthcare a right is consistent with our national values. In fact, it can be viewed as a patriotic act, one that protects our citizens and serves our country. So I'm going to move towards the last segment of what I wanted to share with you, and then we'll open it up for discussion once again, which is I would like to close on a positive note and really move into like what it is that you can do, even if it needs to be virtual. So let me go back to the other slide, and I want to read one last excerpt because the metaphor for this book is the Women's March and the Marching Toward Coverage and all other marches that have accomplished so much social progress in our country. I was very inspired by the civil rights movement as well. And so I want to share with you a little bit of that. The first where I introduce this, I start this chapter with a quote by Alice Walker, which is, "The most common way people give up their power is by thinking they don't have any." That was a quote a lot of people put on their signs that I really liked. So let me start. Early in the morning on January 21st, 2017, I stood at the corner of Independence Avenue and Maryland Avenue Southwest. Not far from the U.S. Capitol building, shoulder to shoulder in a sea of other protesters, I waited for the Women's March on Washington to begin. I saw people holding handmade signs that read, "I will not go quietly back into the 1950s," and "Well-behaved women seldom make history." Others were starting to chant refrains such as, "This is what democracy looks like." There was my mother, my oldest daughter, my sister-in-law, and my friends, including Wendy, who just spoke up. I sensed the awakening of a community spanning generations and all walks of life. At that point, though, I had no idea that this event would turn out to be the largest single-day protest in American history, with up to 5 million of us advocating for issues like women's rights, immigration reform, the environment, and tolerance. But the Women's March wasn't only massive, it was also high energy, determined, and peaceful. And the combination of these elements was what made that day so incredibly uplifting and empowering. The 2017 March inspired countless women to engage in efforts to promote equality and justice, whether by getting more information, voting, joining committees, or even running for public office. It was one of the key factors from that year that inspired me to write this book. In short, the collective action of the Women's March created positive change and showed us once again that activism works. Activism has proven itself over the course of many years and many issues, including healthcare, where in 2017, the organized resistance defeated numerous attempts by Republican legislators to repeal the Affordable Care Act. The threat of millions of people losing that health coverage was real, and Americans across the country responded with activism, marching, protesting at town hall meetings, flooding Congress with calls. I participated in many of these events and was continually astounded by not only the turnout, but the energy, determination, and focus that I witnessed. And through it all, women have been leading the way. Women were at the forefront of the public protests, and they made the vast majority, 86%, of the calls to Congress defending the Affordable Care Act. More recently, in the 2018 midterm elections, women reported voting for Democrats over Republicans 59% to 40%, presumably due in part to the importance of the healthcare issue in the election and Democrats' consistent stance of protecting access to healthcare. But if we want our government to recognize healthcare as a right, women need to do even more. A primary reason is to address the challenges that women face as caregivers. The healthcare system is just not meeting our needs. The ACA expanded healthcare coverage to 20 million Americans. It established the consumer protections and it made healthcare affordable for many, but it did not go far enough. Too many people still lack health insurance coverage and too many others are worried about not being able to afford theirs. To put it in terms I've used before, we need a fleece blanket that provides full coverage, not a patchwork quilt with bare spots. However, the healthcare system is not going to ensure access by itself. We, the people, must make it happen. How? With political activism. So we'll go to the next slide, and that you saw a sneak preview of it, but this is the women who were newly elected to Congress celebrating their victories along with some who were already there, and they're wearing suffragette white. And they are I think all of these are Democrats. But there was a big surge in 2018 because so many women were motivated to be courageous and so many other folks supported them that we got the highest level of representation of women in Congress that we've ever seen. That said, it is still only 24%. It is nowhere near 50% or 52% where I would think it should be, but we made huge progress. So, and that was with activism and truly taking democracy at its word and doing everything that we can, which includes voting. So that, to me, was a very powerful outcome of what we saw from what was a powerful gathering of women in the 2017 Women's March. We'll go to the next slide. So when you think about what does this mean for you and how can you get involved, in my reading, I mentioned some of the options, and I have a lot more information available to you on my website, and I'm going to give you that information in the next couple of slides. But just to frame it, I like the notion of continuums, and we all have different starting points for things in life, and people have different comfort levels with what does activism mean. Some people aren't even comfortable with the word being an activist. They prefer advocate. But activism does mean taking some kind of step up into the political arena. It doesn't necessarily mean that you have to be outside marching, and none of us really can do that right now anyway, so we have to find other things we can be doing. But I look at it as, at the beginning, you got to be informed about the issues so that you aren't intimidated and don't get talked over on these issues. And you don't have to be the world's biggest expert on it. You can speak from the heart, and that's the next thing, is to share stories that talk about why coverage is so important. That's why I shared that story of Amy Villela in Nevada and how she tragically lost her daughter, who was ironically going to nursing school, but had a coverage gap and was dismissed by the hospital, and then and absolutely died an unnecessary death in this country. Well, that motivated Amy to run for Congress. And those kinds of things really matter. In fact, as much as I love data, and my friend Kathy, who asked the question, loves data, most people are really moved by stories. And so you've got to have those stories. And so don't be intimidated. You don't have to have all the facts and figures memorized. Just know that we as a society, we're wealthy enough. We can, if we make it a priority, we can do this. So sharing stories is a very powerful way to connect with people. And then moving on up the continuum, you can support the cause. You can do that through your financial donations. Women tend to not give as much politically as men do. You can speak up, test it out with a safe group where you can test out your talking points, but then take it up a notch. Don't hold back. There is a confidence gap that's well documented for women. Not all women, but on average, there are a lot of times where women's like, oh, I just got to do more homework. As soon as I've done all my homework, then I'll raise my hand in class. I mean, it starts there, and then and it progresses on through life. So it is really, I want to encourage people to get more comfortable in this subject matter, again, without feeling like you have to be the world's biggest expert. Showing up is great. Right now, we're going to do that virtually. Organizing, that can all be very much done, and I'm a fan of social media for that purpose. And running for office is kind of way out there at the far end of, I'm sure, beyond most people's comfort zone in this room, but you can support the people who have the courage to run for office. That is vital, because you can't just leave it to the independently wealthy people to run for office. We have to support those who are willing to step up. So there's a lot you can do where you never actually have to get on at a podium and speak. You can just support the people who are willing to do that. So those are the things along the continuum. Much more about that both in the book and on my website. So let's go to the next slide. So I'm going to start with some of the lower hanging fruit kind of actions you can take. Here's some specific examples. These slides will be made available to you after this session as well. So of course, I have to say you should buy a copy of Marching Toward Coverage if you haven't already. And get one for a friend or a relative or somebody or two friends, because a lot went into this book. There's so much good. Oh, wow. Showing. And what I want to say is that it is a well-documented book. There's a lot of endnotes, but you don't have to read those. Just know that it's legit. It met very high standards of approval. So there's good information in here, but there's also just stories and things. I tried to make it really accessible, knowing that not everyone in the world really super policy wonky the way I am. So my publisher, Beacon Press, was so helpful in getting me to find the right balance between being factual and, you know, legit support the info without overkill for everybody. So a little bit of data, more stories, and hopefully this compelling art that you'll like. And so you'll be informed, and the people that you share it with will be informed. I'm also happy to speak. I like to speak to people live best, but I will do virtual in lieu of being just sitting on my couch. So I'm happy to, and virtual actually has a lot, there's no travel involved. There's a lot fewer transaction costs. So virtual is kind of very efficient in many respects. Kathy's smiling like I'm coming to see some benefits of it for sure. So I'm happy to do that. Lunch and learns, whatever. I will show up. Please add your name to my list if you weren't already on it. Some people were invited by others to this event. So just sign up or put your name in the chat and then you'll get updates from me. Take the quiz. This is an easy 10-question quiz on my website so you can assess where are you in your comfort zone on personal activism. And then I want you to commit to increasing that activism based on your quiz results. So from wherever you're at, move yourself up a step. And we'll go to the next slide for some ideas. But before we do, I want you to identify 3 friends. Remember those Post-it notes. If you can come up with 3 people who you would share this information with, whether it's the slide deck, a link to the book, my email address, so I could go talk to the group that they organize, their book group, whatever, please share. So think of 3 people before we close. Moving to the next slide. So there are all kinds of ways you can commit to increasing your level of activism. When I have in-person events, I hand out a card and there's this checklist on it. And in this checklist, I haven't checked any boxes because I want you to do that. And maybe you just do it on your Post-it note, or maybe you download the slides and you print it out. I don't know, go old school. But please consider doing at least one of the things that's on this checklist. And this is the stuff that I already referenced in that continuum of involvement. And, you know, it could be as simple as I'm going to sign up for some healthcare activism alerts. And then you say to me, Rosemarie, where do I do that? Well, if you go to my website, we have a list of resources and organizations that are doing this. Because no, I am not starting a new organization to do this. It is not necessary. There's awesome people out there already doing this. And you can sign up to get the information. You can sign up to support them, whatever. And please, 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 if nothing else, make healthcare a priority in your voting decision. So I'm going to go to is that the last slide coming up? Oh, second to last slide. So if you were wondering how you can get the book, it is on sale anywhere books are sold. I'm supposed to be even-handed in how I promote the venues from which you can buy the book. I'll be honest, I'm very concerned about independent bookstores. They are wonderful. They host authors for events. They are like the lifeblood of the writing community, and I'm honored to be a little bit in the writing community now, not just the reader community. And bookstores are the best. And so many have had to close during this crisis for, temporarily, but I'd like to keep them in business. So you can go to IndieBound or Bookshop, and even though you might today have to buy online, it will help these bookstores. So that's really important. There's also audiobooks if that's your thing. That's available too. And then last but not least, if you want to be in touch with me or follow in any other way, the last slide just gives you my email address, and I am sharing my author journey on Instagram, and I also tweet pretty actively and politically. So if you like the politics of this talk, you'll like my tweets. So can you just go to that last slide, Maria? If you have, yeah, there we are. So if you want any of my handles or what have you, that's where I am. Okay, we have, I think, 15 minutes left. And this is really to open it back up for a conversation, questions, whatever you would like. And if we don't get to everything, I'm committed to responding one way or another. So we'll have a record of the chat and I can get back to you. But let's see what we've got.
So we've had a lot of comments. Thanks everybody for a really vibrant conversation. If you would like to vocalize any of your comments, please feel free just to unmute and go right ahead. It seems to be working well. Mm-hmm.
I'm taking a picture.
Cool.
Because when I have
Hi, everyone.
I like to have a record of it. So this will be my new way. Okay.
There you go. This is Allison Corcoran, Rosemary. Thank you very much for the talk. And for those of you who haven't read the book, it is very accessible and talks about a very complicated topic in a way that makes it understandable and highlights the stuff that really matters. But my question is, in this, around this discussion of how do we make healthcare a right, I think we've sort of gotten to this place where we sometimes just say Medicare for all without really maybe tapping into that in quite the way we could, because it seems to me that we've decided that healthcare is a right for older Americans. Healthcare is a right for people who have made it through the incredible hurdles to identify as disabled. So we've said healthcare is a right for some populations. Is there anything we can do there that kind of connects to that and says, well, if we've made that decision, how do we expand that to in a broader way? So that was just a comment. And then my second question was, how does Medicare compare to some of the other countries, the coverage that we have through Medicare? How does that compare to some of the other industrialized, developed countries that have universal health care? Is it comparable to what others might need?
Okay.
Or what others offer, I guess.
Those are great questions. And thank you for the shout out about the book. And anybody who has read it already, and if they like it, I would very much ask that you put up a review on Amazon or on Goodreads, places that people look, because especially with having fewer live venues right now, the way that books are able to get out there is through word of mouth spreading. It's just like old fashioned, except for that it's, done online, but it is like person to person. So people read that and it really matters. It's the influencer thing, I guess. Okay, so thank you for that. But to your question, so Medicare for All, Bernie style, is a very dramatically enriched program compared to what Medicare is for older Americans and disabled folks today. So it took that term Medicare just because it was kind of like people understood that meant some kind of guaranteed health care and pretty robust. Bernie's version adds on a bunch of things that Medicare, our Medicare doesn't even cover. And similarly, Canadian Medicare, which is an example we often look to, also doesn't cover. So that means it's very, very expensive. And in my view, is fighting off more than we can chew at this point. And I worry about when you are too ambitious programmatically, it can backfire. And because we've been on such shaky ground with even just maintaining the Affordable Care Act, I would hate to be, back on that thin ice and even lose ground potentially. So I worry about that. That's my pragmatic side. So Medicare, as it actually is as a program in our country, compares, I think, favorably to what a lot of other industrialized nations have done. And when I say they've made healthcare a right, it doesn't, what they have said, it's succinctly described by one British health minister: we cover everyone, we don't cover everything. And I think that's what's key to remember. Like, all societies have to come up with some kind of prioritization. We don't have infinite resources in anything that we do. So there has to be some way to sort things out. But unfortunately in the US, we've veered towards allowing folks with means to have, you know, very high-end extra things, and I think really at the cost of folks with lesser means being able to access even basic things that should have been solved, things that could have been cured. And we're a little out of whack that way, and it wouldn't take tons of money to reallocate. It's a mindset, I think, and about priorities. So we're not in our Medicare program that's as similar because it doesn't cover everything. You know, there are gaps, and that's true in the other countries. I mean, in Canada, their Medicare program, which is what they call healthcare for everybody, doesn't include prescription drug coverage. A very minimal amount, I think, only for people who are disabled. And so that has to be a supplemental benefit that people buy or employers provide. So, you know, there are nuances to all of this, but I think we still need to get to the cover everybody part. That's why I keep bringing in that fleece blanket. So maybe it's not like some big fancy down comforter, but, you know, let's at least get everybody to a place. Does that answer your question?
No, thank you. Helpful.
Yeah, and in terms of making something a right, to me, that's the aspirational thing. You know, K through 12 education is a right in this country, but as we well know, we don't administer it evenly at all. But at least we're not saying, geez, is that kid deserving of being in kindergarten? Or, you know, should we take that away from, you know, the K through 3-year-olds in Nebraska or whatever? Like, that's just not even on the table. We accept that as a civilized society, we're educating our K through 12 students. We have a long way to go in terms of, you know, the inequalities, but we've achieved some baseline agreement, and we have not achieved that for healthcare. Other questions? Discussion?
It looks, oops, I just lost it. Yeah, so we had a question from Jenny White. Jenny, I'm going to unmute you right now. All right, Jenny, we should be able to hear you.
Okay, can you hear me?
All right, yes, we do, thank you.
If we manage to elect a majority Democrats in the House and the Senate, what would you think would be your first priority, your first policy, first legislative steps to take to sort of march towards coverage, full coverage?
I love that question. I almost feel like I should have planted that one. That's such a good one. First, I would have a humongous party, and hopefully we'll be far enough away from this coronavirus that we could literally have a big, huge party and go back to Washington and just like have a wild celebration. That's what I'd first do. And with that energy, then move into legislating. And the low-hanging fruit would be to restore the things that are already in the law but have been undermined by the Trump administration. So in the Affordable Care Act, restoring those things. And then you could take, you know, I think Joe Biden's got some good ideas in his plan of how you could make the subsidies more generous under the Affordable Care Act. So you wouldn't have to like even revamp the law. You could make it more like the way we're doing it in Massachusetts, which is the same framework, but it's more financially generous. And we have 3% uninsured in Massachusetts. 3%, and that's with this framework. So you don't have to necessarily do something majorly different in magic. You just need to invest some more in it. I would also want to do something for kids. 4 million kids being uninsured when most of them are eligible for something is ridiculous. So we should, when you sign up for food stamps, you should automatically be enrolled in health insurance. Like, it shouldn't be this ridiculous paperwork process that parents don't understand. Frankly, it should be just like when you're born, you have some sort of baseline coverage. So I would do those two things for sure. I wanted to say one thing about Allison's question earlier, because I just remembered you'd asked about making healthcare a right. I wanted to make the comment, I made it at a guest lecture I did earlier today, that we went a long way toward making more of our healthcare a right by guaranteeing coverage for people with pre-existing conditions. I can't say it enough. I've talked about it earlier. You know, that is a universal thing because unlike Medicare, which is focused on the elderly or the disabled, and Medicaid, which is for the poorest of the poor, pre-existing conditions are completely across the board, regardless of race, income, anything. And they are protected by the Affordable Care Act. So regardless of your coverage today, whatever, if you fall into gaps, you are protected. That, in my view, took us a lot further toward making healthcare a right. And the fact that people fought for that and did not want to lose it is, to me, so gratifying. Because when I first worked on health reform here in Massachusetts, you know, and I didn't even exactly know the phrase pre-existing conditions because I hadn't worked in commercial insurance. I worked in government in the Medicaid program, and we covered anybody who qualified. It was based on your income test, not your health status. We never looked at your health status other than to try and help you manage your health, but it wasn't a barrier to entry. So I was like, what is this thing commercial insurance is doing? I did not understand it. So my, you know, then new boss explained it to me, and I was appalled that we had this situation. But it was a mouthful. It didn't, you know, it didn't catch on until it was threatened with being removed. And enough people, there's enough of us who have them, pretty much all my friends and me, we all have existing conditions at this point. You know, we know what it means now. So I think that was huge progress. And for American standards, a relatively short amount of time. So from 2006, when I went in and started working on health reform, to now, you know, it's less than 15 years. That's kind of fast for us.
So thanks, Rosemarie. Being cognizant of time, we just have a few minutes left. We have time maybe for one more question and final comments. So any final questions?
So hi, my name's Ellen Katz. I've really enjoyed this. Thank you. I guess the question I have is, how do we change the mindset of, for, you know, we heard so much even within the Democratic Party of people being afraid that they're going to lose the good coverage that they have if we expand healthcare. And how do you change that mindset so that it's not like a zero-sum game?
Right. Well, so that's why I was really concerned about the politics around Medicare for all, because I embrace the notion that healthcare should be a right. I'm completely on board with that, and I'm glad that Bernie has brought so much attention to the issue. But what's scary to people is if they have coverage that they know, they understand, they like it well enough, it's scary to think that, oh, we're just going to, you know, eliminate that and put you in a government program. A lot of Americans really don't trust government well enough to feel like they want to put their healthcare there. So I think that is just more than people can handle in terms of change. And so I put in the book other paths that you can get to making healthcare a right without, frankly, scaring so many people.
I accidentally muted you. So Rosemarie, we have one final question.
Sure.
So Judy asked, any thoughts on how to mobilize mothers of children with special needs? I've thought of my niece throughout this talk, who in the past few years has become a powerful advocate for her daughter and family.
Yeah, well, there are, oh my goodness, there is an amazing organization. The head of it, or one of the co-founders of it, is Elena Hung, and I think they're called Little Lobbyists, and they did a ton of the mobilizing. They had very severely disabled or ill children, you know, who were often, they're young and they were born with some really challenging conditions, and a number of them are on Medicaid. And so when the Affordable Care Act was threatened, which included reversing Medicaid expansion possibly, or block granting, or whatever they were going to do, Little Lobbyists formed and mobilized, and was incredibly effective, because the stories that the mothers were sharing and even bringing their children to do the lobbying was amazing. And you know, a number of people said, okay, there was like, members of Congress could not ignore that. It was very powerful. So mothers can do a lot. And even if you don't have a child who's severely disabled, you can have radical empathy for the people who do, and be there with them, stand with them, you know, literally or virtually, and it makes a huge difference.
Thank you, Rosemarie. And you're just getting a lot of positive feedback here in the chat. People are saying, wonderful talk. Thank you so much. Thank you for your vision and your passion, Rosemarie. Maria commented, thank you everybody for your very thoughtful questions. Angelique said, we're very proud of you. So a lot of really positive feedback in the chat box for your amazing presentation.
I see a lot of familiar faces, dear friends, and oh my goodness, it makes me really happy. Thank you so much. And for those of you who I have not yet met, I hope to meet you one day. Please stay in touch, and please do keep on marching.
Thank you. And to everyone on the call, we'll follow up with an email with resources. So stay tuned, and I'll CC Rosemarie's email so that if you don't have it yet, you will, and you can follow up with any other questions you have. And also, you know, please do buy her book. It's an incredible resource in this very important time. So thank you, everybody, so much.
Thank you. Thank you all. Have a good evening. Bye.
Bye. Good night, everybody.